Hi, everyone.
Hi, Andrew. It's Khadeen here.
Oh, are you back?
I'm back today. Yes.
Sure. I am truly regretting signing up for this talk. You know that.
What show is it?
It was a bit of more than I could chew.
A
Yeah.
weak moment.
Yes.
Sorry, but thank you then.
Can I just see? Oh, I've got gazillion things. Let me just
Do you maybe
see.
want to just share your screen?
Um, hang on. Uh, there we go. That picking up.
Yes, just put it in presenter mode. That would just make sure you
Okay.
have the right screen there. Perfect. That's
Yeah.
awesome. All right.
Cool. Okay.
So we've asked Charlene to chair.
Yeah, I
So
see.
I'll
Yeah.
share our slides, the intro slides, and then she'll go through it and then hand over to you.
Cool. No problem.
Awesome. Thank you. See you
Okay.
off.
Cool. Yeah. Okay.
Bye. Hello, Charlene. It's Gardine here.
Hi, Nadine. How are you?
Well, and you?
Okay, I thought you were leave.
I'm back today.
Oh, okay.
We
Never
ordered,
mind.
she fooled us.
I was
Anyway,
away, but I'm back today.
Okay,
But
welcome back.
thanks. Bridget did a very good job standing in for me.
Hi, Bridget. Hello, Andrew.
Shame,
Hi,
Charlene, I see you're chairing today and next week, it seems like.
Yeah, I am.
Oh, shame. You can let me know if you want me to look for someone else for next week, or are you happy to do that?
It's fine. I'll
Okay.
do it.
Okay.
Farah is doing most of the talking anyway. I just have to
Yes.
introduce and
Okay.
yeah.
Awesome. Do you want to share the slides or do you want me to give you control of them? What do you prefer?
No, rather just give it to Andrew because he's presenting. I will just speak. Is that okay?
Yes, well, I can also go. It's just for the introduction. Did you
Yeah.
see these introduction slides that you just
Oh
speak
gosh.
through?
No, I did. Oh, can you do that then? Sorry, because I'm
please.
speaking off my iPad. So
Oh, shame. Okay, I'll do the talking then.
And
I've got
Charlene, less is more, hey?
yes,
Okay,
I'll
Introduction.
keep it very short.
okay, Andrew.
Perfect. Andrew, let's see what you
like,
have for your intro here.
no, nothing, no, that's horrible. That's horrible. That was like a bump written way years ago. Anyway,
Okay, so
fine.
Andrew is a clinical hematologist in Pretoria. Happy
Yeah,
with that?
That's it.
Awesome.
Quite
I'll do
happy
that
with
then,
that.
and then I'll hand over to you.
Okay, thanks.
Cool.
I'm glad I'm sticking with the European tradition of providing years out of date photographs.
So, who will know?
No, I mean, if you go to these meetings and you see these Europeans going like this young person picture gets put up, and then it's like
Oh, yeah.
old geezer climbs up on stage, and you go like,
Who are you?
okay.
Well, I recognized
you're
you
like
at
that
the
now.
from your picture, so it's not that bad. Yeah, Charlene, so do you want me to also welcome everybody and talk through the intro slides, or where do you want to say something? Do you want to say something?
I don't mind speaking if you just move the slides.
Okay, let's do that then. So once we between 30 and 40 people, which I think we will have reached by 4, you can just start. Can you see the slides on your?
Yeah, I can see the slides.
Okay, so it's basically, the housekeeping. I'm sure you're
Yes.
familiar with them by now. And then we can just quickly go over that.
Okay.
And then Andrew is a hematologist in Pretoria, and that's that.
Okay. Thank you. And I know we are doing next week, so.
Yes, so you will know even more than us. Okay, awesome.
Okay. Thank you.
Speak in a bit then.
Okay, thanks, Kadeen.
Bye.
Good afternoon, everybody. Welcome to this afternoon's session of Deep Dive. And we will be having a special guest today, Dr. Andrew McDonald, who will be speaking on management of relapsed refractory AML. I will wait a little while for more participants to join, and then we'll do our introductions. Our session today is actually being sponsored by AbbVie, and we'd like to thank them for that. I think we had 47 participants now, so I will wait for a little while. Okay, we are sitting at 52 participants. So I'll start with the housekeeping notes. So all the recordings from Deep Dive are actually found on the Blood Assay website under resources. The details are on the screen. Please, during the course of this, the session, add your questions into the chat box, and we will try and get to them at the end of the talk. And we would also welcome people to actually raise their hands and actually speak on this platform. So if there is anyone that's not on the mailing list, please could your request be sent to Melanie Davids. The email address is on the screen, melanie.davids@uct.ac.za. Your CPD points will automatically be submitted to the HPCSA. So ensure that you're attending on your own registered Zoom account. And if there are any queries, please also contact Melanie Davids. There's 1 point for a 1 hour attendance. At the end of the session, there will be a feedback form to fill in. It takes just a few seconds. Please do fill that in because it gives us some valuable feedback on how to improve or going forward. Positive feedback is also welcomed. So I see we're sitting at 63 participants. So we'd like to also thank the management team of Blood Assay, Professor Stelfer Berg, who is the team leader, Hardin Kritzinger, he's the National Training Coordinator, and Melanie Davids, who's the CPD Administrator. And we'd like to thank them for all the effort that they've put into actually making this such a successful platform and sending out the emails and getting us all together. So thank you guys for your efforts. So without further ado, I would like to introduce Dr. Andrew McDonald. He said that we shouldn't say too much about him, but I've known Andrew for a good few years now, and what I can say about him is that he's a really, really wonderful person when it comes to sharing of information, and personally has helped me with a lot, and really a very kind person. And Andrew, I will hand over to you, and you'll be talking to us about treatment of relapsed refractory AML. And I'd like to thank AbbVie again for sponsoring this session. Over to you, Andrew.
Thanks, Charlene. Can you all see my screen?
Yes, we can.
Cool. Okay, so thank you to Deep Dive. I actually had no idea that AbbVie was sponsoring this, but thank you to AbbVie for doing that as well. And sure, I'm going to say it was quite a challenge to put this talk together, and I think a bit of more than I could chew when I offered to do this. And I must say, this is going to be the opposite of a deep dive. It's going to be a whirlwind tour through relapsed AML. A disclosure. So obviously, lots of my AbbVie, we actually took part in VRLE-A and VRLE-C trials. So the foundational trials for venetoclax use in AML. In fact, we've still got one patient on VRLE-C who's going on 79 years old, who's onto his 66th cycle of chemotherapy on VRLE-C of all trials. So looking at just going through the outline of my talk, so I'm going to introduce AML very briefly, I guess, because most of you should know at least something, but I have to say some basics. Then talk about clonal evolution in relapsed refractory disease, and then the Ven-Aza data, second transplant, and then targeted therapy, and then end up hopefully closer to 5 o'clock. So obviously, AML therapy has undergone a revolution in the past 2 decades. I started doing hematology in 1999. I think our therapeutic options in 1999 were 3+7, and I guess the research questions then were, what dose of anthracycline and protip more is better, which is actually quite interesting because Nick had really pushed us to higher doses very early on in that whole process. And then obviously getting people to transplant if they were young and fit enough. FLT3 had actually only been described in an AML cell line and really hadn't kind of reached a clinical horizon when I started, and nucleophosmin 1 mutations hadn't even been described yet. And obviously all the rest of the slew of mutations that you see now on a myeloid and next-gen sequencing panel obviously hadn't been described, and the tools to utilize them in routine clinical use were still essentially decades away. So AML, when I started, was actually quite easy, and when someone relapsed, well, that was pretty much it. You could talk about doing second transplants, but the reality was that most patients actually died. And even in 2018, the comment was, for AML, relapsed refractory AML is really one of the most challenging issues to treat in hematology. Less than 10% survival in many centers. And also really what we have kind of forgotten about, we've fixated as hematologists, not unfairly so in a resource-limited country, on the young and fit patients. But obviously most of the patients who present with AML are frequently elderly, frequently have secondary or therapy-related AML, and the issue in terms of relapsed refractory disease is also that they acquire new morbidities or comorbidities as we go along, anthracycline toxicity and cardiac issues, and then what we've certainly been seeing of late is the complications of therapy post intensive chemotherapy induction, and particularly sepsis. So a lot of our patients with AML, even in young patients, are arriving colonized with multi-drug resistant organisms, particularly CRE, Klebsiella. And these patients often crash and burn during induction therapy with Klebsiella septicemia. And really, we've actually made a decision to, given our incidence, which is not mostly intra-hospital acquired, the patients are coming with it, to actually proceed to ceftazidime avibactam as our primary therapy for patients at high risk. So obviously that really sort of makes the point is that, do we carry on with intensive chemotherapy? And I think the overarching theme of my talk, if you want to take away, is that, do we do the same or do we do something different? And I've put 2 quotes there, one from C.S. Lewis saying, you can't go back and change the beginning, but you can start where you are and change the ending. And the other from Lao Tzu, if you do not change direction, you may end up where you're heading. So I think the overarching theme of this talk is going to be, can we do something different? And with the many new drugs and less toxic drugs offered to us now, the question is, where do we go? So I'm going to start off with a case. I'm not sure if Jacques is actually on the call as well, but he also knows this unfortunate young man. So This is a 16-year-old man who first presented to us in October of 2020 with 2 to 3 months of malaise. He had AML with multi-lineage dysplasia. I can see I put the flow cytometry down, but again, it'd probably be pretty meaningless outside of some really dedicated pathologists looking at that. We obviously at the time didn't have his karyotype, but we were really concerned about the significant multi-lineage dysplasia that was present on his diagnostic biopsy. But in the end, actually, the karyotype came back as 46XY. There was no PCR sample sent for FLT3, and also importantly, in the early days of NGS with the chips and trying to fill chips and less patients being requested and less tests being requested, and we were getting our our NGS results back quite late in the day, and this young man had a very low level of a variant allele frequency of 6.6% of a TKD FLT3 mutation. So we were actually very concerned about his multi-lineage dysplasia and decided this would be a candidate for flag IDA induction rather than standard 3+7. So as noted, really no midostaurin given up front because of the late FLT3 result. We know midostaurin is active in TKD mutations as well. So unfortunately, we did a day 21 bone marrow, and he still had significant disease, 20% blasts present, with no acquisition of a TP53 mutation. And we watched him for a little longer, but at day 42, he still had significant disease and remained pancytopenic. So the question was, where do we go from? Yeah, he really actually had intensive chemotherapy, not just really a standard 3+7, which is obviously intensive in its own right. Getting gilteritinib, well, gilteritinib had been registered in the world, but it's really not affordable in South Africa. So we made a decision to proceed to decitabine. This is a 5-day cycle, not a 10-day cycle, as has been described in some circumstances in the literature. In addition of venetoclax, and the venetoclax was actually azole boosted, so we can, as most of us have been doing in South Africa. And this was followed by a haploidentical transplant from his father, which is relatively young, ABO matched peripheral blood. So you got the 4 cycles. Interestingly, obviously, this is in the bulk of the COVID era, and he got COVID between cycle 1 and 2, but actually rapidly cleared it, and we went on to cycle 2 without much ado. He had platelet recovery post cycle 2, ongoing mild anemia and severe neutropenia, which never really ever got better. But by post cycle 3, he had CRI. Really, the neutrophils were the main issue in terms of recovery. MRD was positive, and then proceeded to his haplotransplant in June of 2021. So the initial actually time after transplant, the first 2 weeks was actually quite uneventful, and he was actually an early discharge. We often keep these patients until 3 weeks post-transplant because they have delayed count recovery. He was early count recovery and went home at day 16, but was readmitted on day 24 in acute renal failure, creatinine of 900. So really, as he'd gone home, the wheels had started falling off. Adeno and BK virus reactivation, later CMV reactivation, grade 3 acute graft-versus-host disease, which then morphed into a protein-losing enteropathy. He later developed ITP, which we actually treated with romiplostin rather than rituximab because of concern of all of the viral reactivations. Someone has made a comment, and when I presented the story, the case at another meeting, that why didn't we give sorafenib? So there's very good data for sorafenib maintenance post-transplant in FLT3 mutated disease, but sorafenib is not active in the TKD mutation of FLT3, only in the ITD. So we elected not to give him sorafenib maintenance. The poor young man went on to develop extensive chronic graft-versus-host disease following on his acute graft-versus-host disease, which was managed with the corticosteroids, both the systemic and creams, tacrolimus and ruxolitinib. And actually 1 year out, he was still in CR, MRD negative. However, there were lots of social issues in terms of family issues, and actually he was on his aunt's medical aid, and she decided to take him off the medical aid because he was costing her too much money. And essentially actually went on to state 1 year post-transplant. He actually stayed in quite and Jacques graciously agreed to take him over and really pulled out the stops to manage him. And we were slowly managing to wean his immunosuppression and control his chronic graft-versus-host disease. But he unfortunately died 18 months post-transplant from infection. Really, the big issues were that he stayed 300 kilometers from Bloemfontein and even further from us. And he just got one infection too many and really didn't make it to a center in time that was able to manage his complications. So really unfortunate end to what is really post-transplant a disastrous story, but really the point making that someone failed upfront intensive induction was still able to achieve a response and go into remission and maintain that remission post-transplant. So obviously I need to say something about AML, de novo, as well as then moving on to relapsed refractory disease. So obviously when we're staging someone and we want to know the age and comorbidities, obviously prior hematological disease, whether it's a secondary myeloid leukemia or not, prior genotoxic therapies, so really looking for therapy-related AML. And then obviously what's becoming much more important in the current era, and now that we are testing for these mutations, family history and inherited predisposition. I've certainly got a family where the grandfather had a transplant for AML in 2004, and his daughter and 2 grandchildren both have severe thrombocytopenia, and all of them have RUNX1 mutations. So typical RUNX1 family. But DDX41 is really becoming to the fore in terms of elderly AML as well now. Obviously, we want to know the dysplasia, and then obviously karyotype and all the genetics that go with it. And then for those of you not aware of it, I think most of you have seen this, but there's actually now a link to this beautiful risk calculator where you can plug in all of these things, all of these variables, and then we can also generate graphs from like Ellie Papamanuel used to generate, and make me very jealous at meetings when you saw these beautiful survival graphs for AML. You can now do the same for your patient with that calculator. But anyway, moving on, the relapse pretty much the same thing, but really we needing to know prior therapies, whether they had a transplant or not, and the response to those therapies, and actually even more importantly, fitness, and that someone can appear fit for in relapse disease, but they're really harboring sort of just underneath the surface that they're huge issues, and that obvious fitness may belie a significant inability to tolerate intensive chemotherapy. And I put it in a busy slide. I think most of you are aware of the diagnostic strategy, and this is in terms of upfront diagnosis of AML, sort of working your way through all the various subtypes that are now. We've split AML into, so again, the split is of 1, but really some of these are actually very important because they have therapeutic implications. So I've just put it up there, really not a slide to be discussed in detail, but just again that most of you are more likely have seen this. And then some of you may not be maybe pathologists, not into the treating side of things. So just to talk about so the new drugs that have come and are coming, and just to put them all in context. So obviously FLT3 inhibitors are really out there. Midostaurin and sorafenib are registered in South Africa. Midostaurin registered for AML upfront therapy. Sorafenib not registered for that, but is widely available and actually the cheapest of the options, even though it has potentially the most side effects, as it is the most promiscuous TKI inhibitor. So really lots of potential issues. Gilteritinib, not registered in South Africa and really very costly. And quizartinib has had some registration issues with the regulatory authorities. We've been hearing about quizartinib for many years at meetings, but it's taken till now to get to registration. So obviously FLT3 inhibition available to us in part. Glasdegib, the hedgehog inhibitor, really seems to not have really taken off. I think there have been other better options. Gemtuzumab is available, obviously was available in the early 2000s and then temporarily died and then has been resurrected. The anti-CD70 I'm not going to say anything much about, and I'm also not going to say much about immunotherapy in AML, but those are developing fields. We'll say something about the anti-CD47 magrolimab a little bit later in the talk. But obviously the big issue, the big really advance in terms of therapy for AML has been the addition of venetoclax to either low-dose RSC or a HMA, so either azacitidine or decitabine, or even addition of venetoclax to intensive chemotherapy. And then obviously IDH both 1 and 2 inhibitors, ivosidenib, and more recently olutasidenib for IDH1, and enasidenib, not quite as impressive in the IDH2 realm. And then there are certainly looking at menin inhibitors, which we'll say something about at the end of the talk as well. And then obviously we're very well aware of the histone modification, so azacitidine and decitabine, and then CC486, which is the oral azacitidine, a very different drug from the parenteral azacitidine, and ASTX727, which is the oral decitabine, but that's complexed with sidorazine to prevent hydrolysis. So that ASTX727 essentially read as oral decitabine. We're not going to say much about that. Oral azacitidine CC486 has really been utilized in maintenance therapy post AML, and decitabine a lot in MDS. So this is putting it all together, and this is up front, but also in salvage therapy. So we have to at least start somewhere. So obviously I've taken this slide from a talk by Andrew Wayne, modified it slightly, added some things in, but essentially really he's summarized it very well in terms of what the therapeutic options are for varying groups. So first line, if you're FLT3 mutated, 7+3 plus midostaurin, that's certainly available to us. If you've got an ITD, so quizartinib again is also not effective for TKD, but that's an option in some jurisdictions. CPX351, the liposomal daunorubicin, and cytarabine in fixed ratio combination has certainly revolutionized therapy, particularly in more elderly patients where there's been a dysplastic phenotype AML, often secondary or therapeutic related AML. Interestingly enough, the UK AML 19 trial for younger patients really didn't just demonstrate superiority of CPX351 compared to FLAG-IDA. So really that's also really not readily available. I think it has been some use in South Africa. I personally haven't used it. And then if you've got a good risk AML, you can potentially add a gemtuzumab osigomycin to your induction chemotherapy. If you've got an unfit patient, I guess really what's taken the world by storm is Ven-Aza. It's certainly much more difficult to get in compared to azacitidine alone in elderly patients. The cytopenias are significant, and you really have to manage people quite a lot more. But in terms of outcomes and response rates, it's really been a revolution. Moving on to salvage chemotherapy, looking at either flag, IDA, or VEN, and that's really going against my theme of what I'm trying to say. So this is all really intensive therapy, and I'm trying to really steer away from intensive therapy in the relapse setting. We'll have some discussion and present to you some slides from immediate retransplant or transplant, and then I've put in there whether we should not be considering venetoclax plus HMA in the setting of even in a fit patient with a relapsed disease where we're giving salvage therapy. Should we not be considering a lower intensity rather than intensive chemotherapy approach? Just very briefly, seeing as these come up along the way, CR, no extramedullary disease, less than 5% blasts, and you have to have had hematological recovery, neutrophils more than 1 and platelets more than 100. CRH, your neutrophils are above 5, between 5 to 1, and your platelets between 50 to 100. CRI, you've either got neutropenia or thrombocytopenia. And then morphologic leukemia-free state, essentially what we see when we're looking at a day 14 or 21 marrow, when there are no, usually or hopefully no excess blasts, but there's been no bone marrow recovery yet. So now taking me really out of my comfort zone, talking about clonal evolution in apologies for the typo. It should be a / not query r query r AML. But obviously there really are two potentially competing or not necessarily competing, but potential events that may happen in the setting of relapse or progressive disease. And that is either that linear evolution where a clone that has got a couple of mutations is still present and then gains new mutations and then expands and becomes and remains the dominant clone going forward. So essentially linear evolution with the acquisition of new mutations, as opposed to the concept of branching evolution, where there is an initial dominant clone that is predominantly cleared, and then a secondary clone then becomes predominant in the relapsed setting. Obviously, in terms of progression, many patients with AML do acquire new cytogenetic abnormalities at relapse that were not present initially. The majority are more complex, but there is a small percentage who acquire less complex cytogenetic abnormalities at relapse. So essentially, we're looking at a branching evolution type picture there. And the common acquisitions will be trisomy 8, trisomy, so that's trisomy 21, not trisomy 23, and deletion 9. Which significance is unclear, and then obviously the chromosome 5 and 7 abnormalities, which really portend a poor prognosis. And then in the molecular realm, DMT3A, ASXL1, RUNX1, and FLT3 IDDs are commonly gained at relapse. A very busy table, just really saying the same things, that a whole lot of disease mutations often present at initial diagnosis in various groupings, workup of AML patients, and then the acquisition of ASXL1, RUNX1, FLT3, IDD. Interestingly, there's a comment about Wilms tumor 1 being particularly prevalent in relapse post prior transplant, also portending a worse prognosis. So some pretty pictures from a Japanese collaboration with the MD Anderson. This is a single cell DNA sequencing technology. So tools that are not really widely available in the clinical realm, but really in the research setting. And you can see where they've very cleverly kind of looked at varying patients for varying diseases and varying treatments. Obviously, one patient where they achieved a remission, and you can see for many patients, in this patient certainly there's a acquisition of a new clone. So initially ITD, and then relapse with a TKD clone. You can see some patients where the initial diagnostic clones are present, but just really change in percentage presentation, and then patients where, again, there's really a soup of new mutations. This patient acquiring an IDH1 mutation, which obviously potentially renders them amenable to therapy from that point of view, and this patient requiring a FLT3, also, again, a potentially actionable target. So moving on to venetoclax, which we do have available to us, or at least in private, but it certainly really has given us a further potential options in managing patients with relapse. So just to say that both in the upfront and in the relapse setting, IDH1 and 2 AML cells do have a higher incidence or dependence on BCL2. So venetoclax works by inhibiting BCL2. So this is venetoclax over here. The other agents that really are involved in the apoptotic pathways are BCL-XL and MCL1. Now, monocytic leukemias typically have a bit of higher MCL1 and are intrinsically a little bit more resistant to venetoclax, but this is really talking in the upfront realm. What happens in relapse or progressive disease is that cells become less dependent on BCL2 and more dependent on BCL-XL, and a lot more dependent. And this is not invariable, but there is a trend in AML progression to utilizing MCL1 as the primary anti-apoptotic pathway. And really we'll talk at the end about strategies to target MCL1. So resistance to venetoclax might be sort of using your dependence on BCL2, or alternatively a completely different pathway, upregulation of fatty acid metabolism. So let's look at the trials in the setting of relapsed refractory disease using venetoclax with a HMA, either decitabine or azacitidine, or alternatively less commonly low dose RSC. So single agent ven in the early days was obviously looked at in this setting, and it wasn't terribly effective. There were some not unimpressive. I mean, 6 out of 32 CRIs, certainly it's nothing to be sneezed at, but really there are much better options available. So we moved on to looking at venetoclax plus an HMA, and really the problem here is that although we've got great studies in the upfront disease, VIALE-A and VIALE-C, and all the subsequent sub-studies from that, we really have no international randomized trials in this setting. The entry criteria and obviously then the results vary widely. Wide age range in these studies, so looking from the very young to extreme elderly. And they, again, very variable, as you would expect with a very variable trial entry criteria. The outcomes are also very different, ranging from overall response rates from 21 to 62%, and in certain circumstances, CR up to 38 to 51%, and varying survival rates as well. So obviously, this is not necessarily a cure, and if you've got a potential transplant option, still that is certainly the way to go in terms of younger and fit patients. And just to say, there are reports of MRD negativity in this, using this strategy. IDH1 and 2 and RUNX1 mutations appear to predict for better outcomes. TP53 and FLT3, ITD, and TKD, lower responses. There are some patients who've had prior HMA, and again, very variable experience. Some people saying it really doesn't matter. Other people say it significantly reduces the results in terms of outcome in response to re-challenge with an HMA together with venetoclax. Certainly the VIALE-C study, which wasn't in terms of a relapsed AML, but allowed patients who'd had MDS to go into the study having had exposure to azacitidine. The main side effects are cytopenias, infections, and then GIT toxicity. But the one good thing to note across the study is that the TLS risk is actually quite low. So going HMA plus VEN is a significant less toxicity compared to intensive chemotherapy. The actual reasonable rates of responses, which actually do occur quite early, sort of usually within 2 months, which allows you to really to stratify people to go on to further therapy if needed, and obviously allowing people to move on to a transplant if that hasn't been done, or a second transplant if they have relapsed after transplant, with actually relatively minimal morbidity, and really preserving their body to allow obviously the more intensive therapy associated with the transplant. Obviously, the cons in terms of this really are no randomized trials. Quite difficult to put through your funders when you don't have that situation. And then the best backbone for venetoclax is unclear. Do we do azacitidine, or do we do a decitabine 5 days, a decitabine 10 days? And there's some really a lot of debate about which is the best. And if you don't have either of one of those, it's still not impossible to consider low-dose cytarabine. And then obviously the big issue is going to be, if we've seen venetoclax up front, will it still retain its sensitivity down the line? I think that's really too early to say. So moving on to intensive chemotherapy plus venetoclax. I put this slide in. This is actually newly diagnosed AML, so I'm cheating a little bit. Just to make the point that adding venetoclax to intensive chemotherapy, which is really, you can see Donato has now moved over to the MD Anderson. It's really been a MD Anderson thing again, but you can see absolutely fabulous response rates. In de novo AML, 91% CRs. It's really, so looking at, well, 82% CRs, and then a smattering of lower response rate. But essentially, your overall CR rate is 91%. So really excellent results in terms of adding venetoclax. And this is really not the full 28 days. Even in the de novo setting, they've significantly reduced dose of venetoclax exposure because of toxicity. So moving on to the relapse refractory setting, FLAG-IDA plus VEN has been the most commonly described protocol for these patients. Obviously, patients who are fit enough to consider intensive chemotherapy, but the significant reduction of venetoclax to 7 to 14 days, and the cytarabine also reduction, where the usual dose in FLAG-IDA is 2,000 milligrams per meter squared for 5 days. This is down to 1,500 milligrams per meter squared. There's a significant delay in recovery, the prolongation of cycle time to an average of 42 days, but essentially our overall response rates up to 72%. CRs in the 67 to 72% range. And in one study, almost half of the patients who received this, obviously these are younger and fitter patients, then were able to proceed on to a transplant. There is a comment about high fungal infection rates. So you have something you have to really watch out for, particularly if you're a center that has high aspergillus or mucor rates. So really there's no data which is the best option. You get where I'm going, and what I'm plumping for is really the lower dose option, the less intensive HMA plus VEN versus intensive chemotherapy plus VEN. But there's really no data to say which is best. And then moving on to, if you've had a relapse, it is possible to give venetoclax plus azacitidine, followed by donor lymphocyte infusion to immunologically try and get someone back into response, which doesn't preclude them from going on to a second transplant if needed. Apologies for the slides. These are pictures I took at ASH last year. We're moving on now to the discussion of transplant or potentially second transplant. This study was actually a bit unclear whether they enrolled people who had a prior transplant, but essentially this was a predominantly German or European study which randomized people from who had relapsed refractory AML into two approaches. Actually going to we're going to come back to that slide, sorry. But essentially, what they did was randomize people into two arms. One where they went to remission induction. So they got salvage, HAM is intensive, chemotherapy, and then once they'd achieved a response, then they went on to a transplant. They obviously had to have a donor option going into this trial. So that was really one of the main entry criteria, which obviously is a big issue for us in South Africa. And obviously people had to be fit to obviously undergo intensive chemotherapy followed by a transplant. But what they did was randomize half the group to either they've got a transplant waiting and either watchful waiting for people who didn't have a very hyperproliferative disease, or low-dose ROC, or very low-dose mitoxantrone, essentially just trying to keep a lid on the disease or not even treating the disease at all, and then proceeding directly to a transplant using a FLAMSA reduced intensity conditioning. So FLAMSA essentially is fludarabine, amsacrine, and RSC, essentially really a flag IDA or FLAM of sorts. Amsacrine is a modified anthracycline, and then essentially just over a week later you go straight into a transplant with dose-reduced melphalan and flu and very low dose TBI. So essentially a RIC transplant whilst the patient is actually in aplasia. I'm going to back to that. So that's really struggling with the words. What's the process that people undergo in terms of this is that we're not giving them anything to control their disease. Then FLAMSA, which is trying to control the disease, going straight onto transplant, and then moving on. So the question is, how did these people do? So very impressively for this trial, very few people fell out. I mean, randomized 281 and transplanted per protocol. So obviously people had donors up front ab initio, but they only lost just over 10% of their population. Very well balanced in terms of prior disease, ages, and etc. This is a very complex graph, really trying to sort of show you the evolution of each person. Most of the people in the watch and wait or disease control arm got watch and wait rather than needing mitoxantrone or low-dose RSC. Most of them were able to go on to a transplant, and you can see the CR rates after transplant. Some early deaths after transplant. For those who got salvage chemotherapy, you see very low death rates. It's quite impressive for a relapse refractory setting, but obviously very young and fit patients, and obviously no infective complications or concerns. And then either achieving CR or CR, and then went on to transplant. The outcomes essentially similar. Patients who had disease control, intention to treat versus per protocol, very similar outcomes to the remission induction. So this is really low-dose chemotherapy, not controlling your disease, going into transplant directly with active disease versus the HAM approach. Very similar outcomes. So really saying that you don't need to control disease going into the transplant. You just go straight into a transplant. And you either see the Kaplan-Meier curves for these approaches really running parallel to each other. So really no difference between the two approaches. So the big comments I have to say in terms of this approach is this is really exciting. I mean, limiting intensive chemotherapy is a goal that we should all have, and if people have a transplant option, getting them in a good shape and not exposing them to other intensive chemotherapies is really a worthwhile option. I think the big issue is that in a European population where you've got a good chance of finding a donor and recruiting that donor is certainly not our experience in South Africa. And then convincing a funder to proceed to a salvage transplant without intensive chemotherapy, so saying we want to do a transplant but this person is not in remission, is really a hard ask. And then obviously we have to, amsacrene is not registered and relatively expensive to South Africa, but it does avoid the toxicity of intensive chemo. We did play around with Flamser-Rick protocol probably about 8-10 years ago because the German data seemed really impressive. I'm not certain that our local experience at our unit was quite as impressive with Flamser-Rick as what the Germans would say. But it is quite hard to argue with a randomized trial, particularly in the relapse refractory setting. And my question is there not a middle way? And going back to the Ven-Aza data, can't we use that as control and then go into disease with some response and then go into a transplant in those patients who are fit for it? So that's an open question and we can discuss. Okay, so moving on to targeted therapies for patients who've got actionable mutations. So looking at FLT3 inhibitors. So you can see some of these have really been in the relapse refractory setting. So there is certainly some data for both quizartinib and gilteritinib. For sorafenib, we often use sorafenib because we've got nothing else really. I shouldn't say the poor man's, the poor person's TK or FLT3 inhibitor. Midostaurin has really been utilized in first line. So we don't have any experience. Gilteritinib costs hundreds of thousands of rands per month. We haven't managed to access it yet. I'm really interested to hear if anyone else has. Essentially, not wonderful results as a single agent. This is gilteritinib in the blue line, salvage chemotherapy in the red line. But it does open up a slight gap temporarily that if someone is potentially fit, you could consider moving on to transplant. And then the one study, 40 patients did actually get on to go on to transplant, of which obviously 16 patients. So not a lot of people, looking at the initial numbers, 247, but essentially just about a quarter of patients surviving a relapsed refractory disease going into transplant, having received gilteritinib. Obviously, adding gilteritinib to azaven. So this is a study. Actually, see, I didn't attribute this. My apologies to you and to the person whose slide it is. This is actually quite a complex group, really included both newly diagnosed as well as relapsed refractory FLT3 mutated AML. Essentially uses the standard Ven-Aza backbone and added gilteritinib onto that. In terms of data, you can see in the relapsed refractory disease, the outcome's not quite as impressive as in frontline, obviously, but you can see really a 14 out of 70% of patients did achieve a response to therapy, and really, again, if you got another therapeutic option down the line, that would be very useful. But for even patients who didn't, so looking at overall survival curves are really looking really very, very good. Relapse-free survival over there. So the triplet combination is really something that we're going to be probably seeing much more of in the future in terms of therapy, especially for both upfront and unfit patients, and potentially for relapse refractory disease in younger fit patients. Moving on to IDH mutations, isocitrate dehydrogenase, obviously quite a mixed bag here. both inacitinib, which is the IDH2 inhibitor, and ivosidenib, and the new IDH1 inhibitor, olutasidenib. Both often have been used in relapse refractory setting. You can see the IDH2 inhibitor not quite as impressive as IDH1 inhibition, but obviously you can't pick your IDH mutation. You have what you have. But in terms of IDH1, in terms of ivosidenib, CR on CRH of 30%, slightly higher, but probably in range with olutasidenib. Mutant duration of response, it's really interesting. I'm not sure how this trial managed to get such a longer response compared to the initial ivosidenib therapy. But obviously, again, this really begs the question of adding this into a triplet combination. There is certainly data for triplets. I'm not showing it today. But adding a triplet onto Ven/Aza is certainly doable and achieves better results. So again, if you have a targetable mutation, these are things you can do. Obviously, again, I don't think many people in South Africa have had any experience with these drugs. Ivosidenib, when we looked at and trying to get hold of it, was essentially in the 300,000 Rand range. Ivosidenib is also used in cholangiocarcinoma, and I'm aware of at least one of my oncology colleagues who's used it in the cholangiocarcinoma setting. I'm really not sure how that was funded, but essentially really looking at large sums of money that are changing hands to get hold of this drug. Then moving on towards the last part of my talk, P53. So obviously P53 is the big bugbear, both in MDS and AML. So not just because there's a P53 doesn't mean there's necessarily a bad outcome, but significantly high levels or dual mutations of 53. So biallelic P53 mutations are certainly a real major issue, and you can see the centrality of obviously P53 in terms of many outcomes in cellular metabolism, and obviously the resistance to chemotherapy we are well aware of in both in myeloid and lymphoid populations, as well as in solid organ tumors. So what treatment options do we have? There really is the anti-CD47. So the interaction between CD47, which is a don't eat me signal, and we'll elaborate in the next slide or two, and the SERP alpha on the macrophage, essentially trying to block that pathway, which then allows the macrophage to recognize the mutant malignant cell. Obviously, looking at a lot of immune options here as well. TIM3's sabalitamab is also being utilized in studies. So again, a very complex slide. We're not really going to go through it terribly much to say that obviously P53 mutations have been such an issue that really people are throwing everything at it, but very few things are sticking or are in very early development at this stage. So P53 really remains a big issue for us in terms of both upfront patients in de novo AML or myeloid, high-grade myeloid disorders, and also in the relapse setting. So let's just say, I mean, magrolimab has been getting quite a lot of press over the past while. So essentially, the immune checkpoint inhibitor. You can think of this as the equivalent of pembrolizumab or a PD-L1 inhibition in terms of lymphoid and T cell checkpoint inhibition. So this is really the macrophage, where the macrophage recognizes CD47, which is the don't eat me signal, and won't phagocytose the cell. Obviously, a malignant cell may not expose it, might have an eat me signal, but malignant cells then evade capture and phagocytosis by displaying the same CD47 that healthy cells have. So obviously, this really makes it really prime for a target to interrupt that signaling process and allowing phagocytosis and destruction of a malignant cell. So the upfront study. So this is unfortunately not relapsed disease, but this is but really TP53 mutations cut across all the really both de novo and relapsed disease. Not impressive response rates, but I mean, compared to TP53 wild type, and this is a very disappointing result. But in terms of TP53 mutations, this is really something that would be very impressive to have as an option, a therapeutic option. So really, there were actually 2 randomized trials that started. Now, the problem with magrolimab is that there was a clinical hold on the studies at the beginning of this year. I think one of the big issues had been severe anemia, because red cells rely on CD47 to not be phagocytosed when they move through the spleen. And obviously, inhibition of CD47 resulted in some profound anemias for these patients. So there was a clinical trial hold. Then recruitment started again, and a year recently there's been yet another hold. And actually, this trial that took all comers up front has actually subsequently been closed. This one's obviously now on hold, but looking at TP53 mutation patients. So this is again an upfront treatment, not in relapse treatment, but obviously TP53 mutations can persist into relapsed refractory disease. So moving on to the last few slides, the exciting new developments and where we're headed, and potentially, obviously, also in terms of relapsed refractory disease, as well as upfront therapy, menin inhibitors. So finally, there are now drugs starting to target AML or KMT2A for those of you who are younger and less hidebound in their ways. Essentially, ML targets menin and allows transcription of a leukemia. Blocking this really results in blocking that signal from the mutant MLL, and allows differentiation or apoptosis to occur. So this is both useful in the MLL rearranged group, as well as nucleophosmin-1 mutated leukemias. Slightly better responses in the MLL versus nucleophosmin, but really binds into the menin and blocks action. Overall response rates, you can see obviously this is in a phase 1 dose escalation study with the RP2D data, but essentially overall response rate of 52% are quite impressive, and these are really much better even for the KMT2A rearranged. So the MLL rearranged disease, slightly less impressive for the nucleophosmin-1. So certainly we are looking at potential options for this group where we haven't had targetable drugs up until now. And then really just ending off with the shopping list of things. So obviously MCL1, I said right so early on in the talk, looking at refractory AML, particularly uses MCL1 to avoid apoptosis. So there are a whole lot of targets now looking, again, apologies for the spelling mistake, but MDM2 inhibitors, cyclin-dependent kinase 9 pathway inhibitors, P53 stabilizers, TIM3 inhibition, so sabalotamab also sort of coming to the fore, and antibody-dependent conjugate, pivekimab, sunrenine, and then also what I've really kind of missed, but seems to be in quite far advanced clinical studies, is the E-selectin inhibitor, and I'm not even going to try and pronounce that name. So really, it's very exciting. Again, the potential drugs that are coming down the line in terms of options to treat both de novo and relapsed refractory AML. But I mean, really, this still becomes is really still a major challenge to treat and cure these patients. And I think we're all failing and really wish we could do better. Again, there are, as I said, new broad-acting and targeted drugs in development, but again, availability and cost issues. And even if we had them, then the decision is going to be which one to choose if we have potential multiple options. And then still making a plug for allogeneic transplant. It really remains the curative option for those who are fit enough. And then really, it's very interesting to discuss that ASAP trial sponsored by DKMS, whether we go for disease control, urgent transplant versus trying to get them, hammer them into remission, and then go into a transplant. So I'm going to end there, and thank you very much.
Wow, thank you, Andrew. That's a lot of information. I've been taking notes because before I ask my questions, I see there's no questions on the chat. So you started off saying that you have a problem with having patients that have multi-drug resistant bacterial infections. So that with your patients that you start on venetoclax, and what combination are they doing any worse? Is the length of stay in hospital longer with venetoclax? How do you balance all of it?
Okay, so up until now, we haven't been using venetoclax in terms of upfront therapy. So we haven't been using it to intensive chemotherapy backbone. So, it's probably something that we should do and consider in fit patients. Again, trying to pick your patient it will also be very useful to get the results of the workup. Cytogenetics is always going to take a while, but I think the NGS, the time to results have certainly been reducing. So sometimes it's able to wait and sort of get that data prior to starting. But most often we actually forced to start ahead of time. So the results are excellent. The big thing is getting funding. Obviously in the state setting, venetoclax is, let's say, not available, and even private trying to get funding. The question is having some drug at hand and then using azole boosted venetoclax, even if it's for 7 days, it's not going to be extremely costly. Actually, it's really within range of the chemotherapy. Actually, is more expensive than the venetoclax. But again, trying to convince a funder to do that. Certainly, what we have been doing is patients where we've been pushing the boundaries down. The registered indication for upfront therapy for Ven/Aza in terms of newly diagnosed patients is 75 and above, or 65 with at any age with the significant comorbidities. I think what we've been doing is the very young fit patients, we've still been continuing with intensive chemotherapy upfront setting. But if there's any comorbidity that concerns us, we certainly have been proceeding to Ven/Aza upfront in younger patients. And then we certainly have been pivoting a lot more to giving Ven/Aza to either primary refractory or relapsed disease, particularly if they had another prior transplant. You give someone who had taken someone through intensive chemotherapy transplant and then they relapse. They actually look good, or may look good, but once you start intensive chemotherapy, they just crumble. And those patients, certainly we've been considering taking to venetoclax as a cytidine, and then considering a second transplant. And there's been a lot of debate about, do you use the same donor? And actually the answer is, it's quite acceptable to use the same donor, except outside of except in the setting of a haploidentical transplant where your tumor can develop haploinsufficiency. And certainly, we've sometimes changed donors where there've been ready availability of varying options going into a second transplant. but sometimes you're forced to use the same donor if that donor obviously agrees to donate a second time. But I mean, certainly we've been, and it's not a advert for AbbVie and their drug, but and to say that adding venetoclax is certainly, you've got lots of cytopenias. You can't. I mean, we used to send people home on as a cytidine and say, come and see us in a month. You can't do that on venetoclax. That's you need to see them more often, especially up front.
Also, that's my other question with regards to, so you said in private as well, you don't get your NGS absolutely immediately. So I'm just talking the upfront setting, it's 3+7 still, and then you wait for your NGS, and do you change track at that point?
Yeah, so we're trying to push getting the results for FLT3 at least by day 8, because obviously, there's an option to add midostaurin in. Once you've kind of missed that window, it's very difficult to know how do you add midostaurin in a second cycle and a second induction, which we do. I mean, we have done second inductions as well, but again, more and more we're kind of moving to one induction because of infection risks. But as to all the other targeted agents, really, we haven't. I mean, I think someone has given CPX-351 in the country. I can't remember who. I know someone had it, but had access to it. But again, that's extremely expensive. So we haven't been doing the liposomal donor cytarabine combination, and we certainly haven't had access to IDH1 and 2 inhibitors or gilteritinib in the FLT3 setting.
And then with regards to azacitidine and decitabine, how often are you using it in your AML treatment? Either in first, in the first few cycles, or in the relapsed refractory? Because I'm trying to understand what would be the most feasible option in the state sector if you had to choose something for us in states, because at the moment for me, it's still 3+7 is still the most affordable when we have to look at the volumes of patients we treat. But what would your feeling be with regards to the HMAs?
Obviously, I mean, HMAs do come with a significant cost. I mean, they are generics now, so they in private those drugs halved in price. I mean, the one thing we are doing, trying to sort of save money, which is some centers are doing, some are not, in terms of as a cytidine at least, is there is some data using a 50 milligram per meter squared dose for 10 days. And most often that works out to less than 1 vial per day. So using essentially 1 vial per day for 10 days, using 10 vials. At the registered dose of 75 milligrams per meter squared for 7 days, you most often are into using two vials a day, and the drug is not stable. You can't keep until the next day. So essentially, bottom line is on the registered dose, you're using 14 ampules. So that's how we've cost saved across the years with azacitidine is using the essentially equivalent of 50 per meter squared for 10 days. And then obviously we're all cost saving, I think, with the venetoclax. Adding in an azole, which is not wrong in terms of, at least in terms of AML. There's varying in terms of upfront incidence of invasive fungal infection or aspergillus, and but using an azole is not wrong, and then going down to circa 100 milligrams per day, certainly it is a quarter of the cost. So but it's still, I mean, I have to say, Ven-Aza is very expensive. I mean, in private it costs about $50,000 a month, and you still have to transfuse people up the first month. I mean, now we're talking de novo upfront disease. You still have to manage them and transfuse them quite significantly. But for most part, some of those patients are able to be discharged from hospital. Now, again, there's a varying competing costs in terms of outcomes. So it's very difficult. I'm going to say what would be the best of the state. I mean, in terms of if you're going to go low-dose cytarabine, which is relatively cheap, very easily accessible as a backbone, technically you need to use 600 milligrams. That was the VLEC study used the higher dose of venetoclax. But again, using a very strong inhibitor like ketoconazole, you are probably able to bring that again down to 100 milligrams, and just to take the hit and say, well, maybe it's a bit of under treatment. It's difficult to say, given which is the best way to go. But in terms of relapse disease, I mean, I think we've certainly been going a lot in terms of getting patients onto putting that onto Ven/Aza rather than anything else.
So you said something interesting. You said that initially the patients may require more, transfusion. So you're saying in the first cycle and subsequent cycles, the transfusion requirements decreasing, and are the numbers of cycles that you're using?
So I'm not understanding the question in terms of, is this upfront or relapse disease?
Yeah, you said you started saying that these patients need support, transfusion support, usually at the, when you start them, but subsequent cycles, are your transfusion requirements decreasing? And how many cycles? Yeah.
So I mean, the good thing about you should have done a talk on upfront therapy with venetoclax and azacitidine, but upfront these patients, the CR rates at 1 month is very high, and there's an incremental CR rate in the next few months, but the majority of patients who are given venetoclax as azacitidine, who are going to go into remission at 1 month. So the usual strategy is to marrow people at 1 month. If they have recovered their counts, to carry on with the cycle 2 of chemotherapy of venetoclax plus azacitidine. If they're still cytopenic, there really are 2 options. One, it's because of disease, and then you actually have to continue therapy regardless. Or they are in remission and their cytopenias are drug-induced, in which case you actually stop drug for 1 to 2 weeks. So most often people are not transfusion dependent by month 2. So which is really what you're kind of seeing with an induction chemotherapy regimen as well. People who are in remission at month 1 are not requiring intensive or some transfusion support. Let's put it this way. But going into, so the outcomes are pretty much the same. I mean, if I have to say, the CR rates are not quite as high with Ven/Aza compared to intensive chemotherapy. But then you also have to look at the population in terms of upfront therapy that have been utilized. Most of those patients in the world getting upfront Ven/Aza have been elderly. And to have CR rates approaching that of intensive chemotherapy is actually really very, very impressive in terms of outcomes. So obviously the big question is adding venetoclax to intensive chemotherapy induction for younger patients and achieving that one slide slipped in terms of responses is certainly very impressive. But then again, this is the age-old question. MRD does matter, but does MRD matter? And yes. I don't actually know the answer to that question.
So that's the next question I wanted to ask you. You are still aiming for no MRD prior to transplant using these strategies that you have access to, or do you aim for no MRD before taking
for years we said, and look, there's conflicting data out there. MRD is important, but then you have a trial like the ASAP trial in relapsed setting, where they, obviously going into a transplant, not even talking about MRD, they're going in with frank relapse, and the outcomes are comparable. So it really does beg the question: how hard do we push for MRD? If it means blasting away with chemo cycle after cycle after cycle and exposing people to hospital bad bugs, etc., I'm becoming way more disillusioned with that approach.
Yeah.
It's really desperate to lose someone to gram-negative septicemia when you know that they're actually now in remission or have responded to therapy, but they're now dying of toxicity of your therapy. I mean, that's a really difficult thing to deal with.
Thank you, Andrew.
And no other questions. I mean,
Yeah,
gosh,
I'm asking all the questions. It's nobody. It's everybody's still here. There are people on the chat, but nobody has any questions. So I just want to thank you, Andrew. If there's no other questions, I must say this was most interesting with all the newer agents. It's all just a dream for us at the moment in state. AML is a frustrating disease to treat once the patient has relapsed if you do not have a transplant option. And, you know, that's a day-to-day challenge we have. And the other challenge I think we face is, you know, we have access to NGS now, but obviously it takes a bit of a while. But once you have these results, what do you do with them? Because we're still stuck pretty much with 3+7, you know. But hopefully things will get cheaper in time and we could throw in a few of the newer agents in time. But yeah, Benita says, thank you, Andrew, for a comprehensive and challenging talk. So I see there's no other comments. So with that, I'd like to thank Andrew for his very, very informative talk.
Whirlwind, not deep dive.
Yeah, no, it's a lot to take in, I must say, and I enjoyed it. Leaves a lot of room for thinking, and so next week, I think it's our team that's presenting. So Farah will be talking next week with Dr. Abrams from our department, and if everybody could please complete the poll at the end, not the poll, the survey at the end, we'd really appreciate it.
And we Andrew, will do that. And thank you, Charlene, for your great chairmanship. Much appreciated. And your very clever questions. I think we're all a little stunned. Perhaps, Andrew, if you do it next year, we will actually have used a few of these things. So.
Yeah, I'm hoping so too, Estelle.
Thank you very much. It was great, amazing session. So thanks.
Thank you. Bye, everybody. See you next week.
Cheers.